chronic trauma situations in total knee. So what are the problems that we are expecting in a chronic trauma situations? Are a lot of problems that we are expecting. The first problem is a skin condition, soft tissue contractures, particularly the gutters which are stuck, the quadriceps which is sticking to the underlying bone, patellar tendon which is stuck, bone defects that we are going to deal with, the femur, tibia and patella, previous implant, and the most important is the infection, which is a topic in itself. So the skin condition. So if you have a chronic trauma situation, patient. Oh. इकडनं काही दाबू का? So the first problem we are expecting is the skin condition, and the first thing is if the patient has undergone surgery, and in chronic trauma situation the patient might have undergone multiple surgeries, there is the multiple scars. So if this is the condition that you are going to encounter where the patient has undergone multiple surgeries with multiple scars, few of them have healed with secondary healing, then do not hesitate to take help of one of your plastic surgeon colleague and ask him to come down to your surgical intervention, take appropriate help, choose the right scar that you want to take, and with the help of a plastic surgeon colleague. Do not try and dissect subcutaneous tissues, take highest possible thickness flaps and excise that secondarily healed scar so that you end up not having a soft tissue slough or skin problems in the end and end up in problems. The second thing after the skin is going on to the soft tissue contractures. The primary problem that you are going to encounter is the quadriceps. The quadriceps in majority of this time is stuck to the underlying bone or the implant. So do not hesitate to go and do a quadriceps snip. If required, release the quadriceps from the femur. If required, do a quadriceps snip, do a good release of your gutters on the medial and the lateral side. And after that, you start bending the knee. And after that, if in that case also you are not able to bend the knee to 90 degrees, do not hesitate to do a tibial tubercle osteotomy after doing a quadriceps snip and medial lateral gutter release. Without doing this, if you go and do knee bending, you will lead to a rupture of patellar tendon or a fracture of the patella, which will be a dreaded complication during revision surgery. So the next thing that you are going to expect in a chronic trauma situation is bony defects. The defects can vary from location. It can be in femur or tibia. Types can be contained or uncontained. You can be dealing with non-unions or a complete bone loss. So this can be a type of defect that you can be dealing with. This is a case of upper end tibia fracture treated conservatively for around 7 years time, and that's the video that you can see that the patient has a valgus deformity but was able to correct completely. She was treated conservatively initially. So intraoperatively she was bending fully well and she was correcting fully well. So what we can do is we can nullify that defect intraoperatively completely if you wish to go ahead and do. Usually for a valgus knee, I would like to add more constraint to these knees because that leads to a lot of MCL stretching, and progressively these MCLs keep on stretching. So a constrained knee is a better implant for valgard knees. So other type of defects is fractures where there is a central content defect. These defects can be easily dealt with as Neeraj has already shown with metaphyseal sleeves. These sleeves gives you a much better fixation. Unfortunately, these sleeves comes with a mobile bearing tibia, so you'll have to end up in a mobile bearing knee. So the previous implants is the next problem that you are going to deal with. So what are the problems that you are going to expect with previous implants? Using the jigs is going to be a problem with previous implants, particularly if you have implants which are intramedullary. These implants are going to be in your way of sitting the new arthroplasty implants. These implants can cause irritation to the soft tissues. and newer implants might, these previous implants might be in your way of sitting the new implant. So if you are dealing with these implants where these implants are going to come in your way when you are going to put in your keel, you might have to take out these implants. But if you are dealing with such an implant where probably this implant is not going to be in your way for your newer implant, you can skip taking out these implants. So you can skip taking out this implant. Instead of taking the whole incision down, taking out this implant, you can just take out the screws which are going to come in your way for putting a stem onto your femur, onto your tibia. You can maintain the implant on the distal part and continue to do your knee replacement. And those implants which are not going to come in your way, you can just keep them in the place. So the next problem that you are going to encounter is bone defects. So if you are going to get patients like this, where you are going to get a complete bone defect like this, where infection was encountered and the whole distal femur was taken out, or where a patient, the first slide that I have shown, where you are going to encounter a complete non-union after multiple failed surgeries for distal femoral non-union compound fracture, almost 7.5 years old, then you are going to need a lot of new material or newer implants like these, where you will have to replace the distal femur with either these type of conical stems or polycones, or a distal femoral replacement like tumor prosthesis. The last problem that you are going to encounter with chronic trauma situation, which is a topic in its own, is infections. The first important part in infection is to find out the organism. Remove the previous implants, debride it well with or without spacer. If you have done a good debridement and you know the bug, then only my opinion is to put in a spacer or to put in a cement. If you don't know the bug, if you don't know the organism, putting in anything new, you are putting in a new biomaterial which is going to lead to more infection. So if you get a positive culture, then only after debridement put in spacer or put in stimulant with antibiotic loaded material. Involving infection disease specialist into any infection is mandatory nowadays. They know much better than us. They know much better the use of antibiotic and how much duration we should use. Serial use of blood markers, blood parameters to know the control of infection, and at the right time going ahead and doing the second stage is the correct answer to do. So with that, I thank you for your patient hearing.